Hello, this is Shadi Reyes from Midstar Washington Hospital Center. Today is CVI 2017, day 1. With me is Sergey Gurevich. He's a third-year general cardiology fellow, but he's going to be intervention fellow next year. Welcome, Sergey.
Thank you.
He's going to present to us an interesting case of combined mitral and Watchman devices. Go ahead.
So let's begin. So this is, we just wanted to describe a novel way of treating both atrial fibrillation and mitral regurgitation in one. So let's move on. So AFib is present in about 63% of mitral clip patients. A lot of these patients, when we're looking at big studies and population data, 16 to 28% that are on anticoagulation for AFib end up discontinuing for various reasons, bleeding. And then about 18% of these mitral clip patients are actually good candidates for left atrial appendage closure devices. And again, if we're doing multiple procedures, we're exposing patients to risks. Transeptal punctures associated with up to 1.3% tamponade risk. And then certainly other aspects of the procedure carry the same implication. The puncture, repeat intubation, and TE. So the case presentation, this is your average VA patient, is an 85-year-old male, severe MR secondary due to a restricted posterior leaflet. Poor long-term anticoagulation candidate, has been on both Pradaxa and apixaban and warfarin with multiple GI bleeds. His STS mortality risk was calculated at 51% for mitral valve repair, and he's got a slew of other comorbidities, including coronary disease, past CABG, ischemic cardiomyopathy, low EF, prior TIAs, and then hypertension, hyperlipidemia, diabetes, chronic kidney disease. He's even had a PE and had an IVC filter placed for that because he's such a poor anticoagulation candidate. He's got COPD and he's on 3 liters of oxygen by nasal cannula. His CHA2DS2-VASc score is obviously very high with a stroke risk of 11%, and his HESBLED score is high as well. So here is just a snapshot from a TE of his MR. We can see that it's a posteriorly directed jet from his restricted posterior leaflet. So the current practice, at least in the US, due to insurance reimbursement, is this would be at least 2 procedures if you wanted to do a Watchman and a mitral clip, 30 days apart, and obviously exposes the patient to these risks that we just talked about. Yeah. Here's how we started. We carefully went across I guess the challenge with him was that he also has an IVC filter, so coming in was a little bit of a challenge with the 24 French mitral clip sheath. So once we crossed that, we went ahead for the transeptal puncture. Here we can see it in the mid-anterior, posterior, and mid-superior inferior positions. Once we got in, his wedge pressure was obviously very high, about a mean of 29 millimeters of mercury. We got a nice result with a single mitral clip device at the A2-P2 junction with only resultant mild MR and an acceptable gradient of 5 millimeters of mercury. Nice to see a tracing afterwards to see that the wedge actually improved to about 16, which is fantastic. And here we moved on to the second part of the procedure where we're putting in the Watchman device. We have the measurements here. It's about an ostial diameter of about 24 and the length of about 30, 32, 33 millimeters. And so kind of this time we were thinking probably a 30 millimeter Watchman device based on the compression. So this is obviously a successful combined mitral clip and Watchman procedure, resulted mild MR. Significant drop in the wedge pressure allowed us to wean him from 3 liters of oxygen to room air. We avoided repeat anesthesia, repeat TE intubation, vascular access, all this other stuff that leads to more complications. And certainly the approach, I don't know if it's novel or not, certainly it's been done before, but it's something for the payers to think about, allowing better reimbursement rules to allow for these simultaneous procedures, because ultimately we can reduce significant risk to the patient.